Good afternoon. I wanted to thank everyone for joining us for the webinar for type 1 diabetes and eating disorders, identifying risk factors and effective treatment strategies. I think there are still a few people still logging in and joining, so I'm going to wait just a little bit more while everyone gets the ability to get in, and then we'll go ahead and get started in just a bit here. All right, I'm going to go ahead and get started. Thank you again for joining us for the Type 1 Diabetes and Eating Disorders webinar. We are offering 1 CE credit for your attendance at the webinar. You will be required to complete a survey at the close of the webinar. You will receive an email a few hours after the finish of the discussion. Once you complete the survey, we anticipate that the certificates for the credits will be emailed out within 5 to 7 working days. So if you plan on looking for those, that's the time frame that they will be going in. All attendees are in listen-only mode. If you do have any questions, you have the ability to ask questions via the dashboard, and we'll try and make sure we have enough time at the end of the presentation to address any of the questions that you may have. If for any reason we are not able to get to them, the presenters will circle back and try and answer any questions via email that you submit. So with that, I'm going to go ahead and introduce our presenters today. First is one second, my slides are not advancing. Sorry about that. First up, we have Asha Brown. Asha is the founder and executive director of We Are Diabetes. She's very passionate about talking about type 1 diabetes, especially as it relates to eating disorders, and she brings a wealth of information, and we're super excited to have her joining us on the Castlewood presentation. And second, I'll introduce Narissa Marasso, who is a registered nurse with Castlewood Treatment Centers and has been involved with Castlewood for about 3.5 years, and is very passionate about type 1 diabetes treatment, as one of her children has been identified with type 1 diabetes, and so that's where her passion comes from. And so with that, I'm going to turn the presentation over to Asha and Narissa.
Thanks, Leslie. I want to welcome everyone here today. This is Asha Brown. We're going to start this presentation. I'm going to share a little bit about my background and my history with type 1 diabetes and an eating disorder. So I was diagnosed with type 1 when I was 5, and it was a very uneventful diagnosis because my father also has type 1. He was diagnosed in 1970. And so when I started to request triple-decker peanut butter and banana sandwiches for bedtime snacks and was getting up to pee 8 to 10 times in the middle of the night, my parents knew, oh dear. And so I was not hospitalized. They were able to catch it early before I went into DKA. Obviously, my dad was sorrowful, and I know that he felt some personal guilt about passing on these genetics to me, but I was not very upset. To be honest, I have always been a daddy's girl, and taking shots and testing made me feel like, oh, I'm just more like my dad now. So my childhood growing up with type 1 diabetes was absolutely ideal, and I really want to stress that point here because it's important for everyone listening to understand that no matter what your diagnosis was like or when you were diagnosed, you still have susceptibility to potentially getting an eating disorder when you live with type 1 diabetes. So my example here is that I had a wonderful childhood. Obviously, you can see that this was a promotion photo for the ADA. I started my professional acting career the same year I was diagnosed with type 1, and so the ADA took advantage of that on my father, and we did some local promotion work there. And we can move on to the next slide, Leslie. So I started to feel different and upset about my type 1 in middle school and high school. Let me double back by also saying that by the age of 8, I was diagnosed with Hashimoto's, which is another autoimmune condition that affects the thyroid. By age 16, I was diagnosed with PCOS, which is an OBGYN issue. It does affect you metabolically. I did not present the typical symptoms of heavy weight loss and facial hair, but I did have large cysts growing on my ovaries. When I was learning about all of these conditions as a teenage girl, the main information I came across was the fact that all of these conditions affected poor metabolic control. And these articles were not meant to be shared with an impressionable teenage girl in the performing arts, but they basically sounded like I was doomed to be fat and struggle with my weight, and there was nothing I could do about it. So with that being said, I started to freak out a little bit. I started to, at that point, restrict calories and over-exercise, and became very anxious about my body and the health conditions that, quote unquote, were going to ruin my body. Next slide, Leslie, please. So the other factors that contributed to my decade-long eating disorder was the fact that I got very poor diabetes self-management education. Keep in mind that this was early 90s, and there were different sets of proposed ways to advise patients, and luckily they're different now. But in my day, I was encouraged to go for the angel food cake instead of learning how to properly bolus for a piece of real chocolate cake. So there was a lot of food police stuff going on. There was a lot of incorrect ideas about how a type 1 diabetic should eat. They were really pushing low fat, high carb. I won't go into how we all feel about that. There's lots of different ways to eat as a type 1, but the main thing is that I was not taught how to eat normal food and bolus properly for it. I was told how to avoid foods and go sugar-free and do substitutions, which really set me up for feeling like I couldn't eat certain things. Again, as I mentioned, there's poorly worded information from the media as well as reputable health publications that were giving me a false idea of what I was set up for in life in regards. I never read or heard about anything that encouraged me and told me that I could manage my weight and I would be fine. All I was reading was that I was doomed to be fat, so to speak. The other major factor is that there was a very poorly managed transition from pediatric to adult endocrinology, and I hear this very often in the clients I work with today. Once I left pediatric, I was treated like a chart. My endo, all the adult endos I ended up seeing barely looked me in the eye, really wanted to just treat the diabetes and not treat the person. And as we all know, who are diabetic or work with diabetics, that is not helpful and is not going to equivocate to long-term healthy emotional diabetes care. Leslie, next slide, please. This is a photo that was taken at the height of my food restriction and exercise restriction. At this point, I had been reducing calories and trying to over-exercise as much as possible for about 2 years, and I was exhausted. I'd become very isolatory. My hair started falling out, so I cut it into this pixie cut to try to hide that a little bit. This was a family vacation, and I remember this photo very well because I was very upset by the fact that I had to eat breakfast in front of my family to hide the fact that I, didn't have an eating disorder. And after this photo was taken, very recently or soon after, I read an article in a very well-known magazine. I will not I will not publicly name it, but it is still in publication today. And it had an article meant for teens to read, and it talked about type 1 diabetic teens skipping their insulin to lose weight. And it was not a well-written article because instead of highlighting the dangers and the risks, it highlighted how effective it was. I want to stress that again. This article highlighted how effective insulin omission was. So I read that and then thought, well, why should I be doing all this hard work? I will just eat all the things that I've been told I could never eat, and I just won't take my insulin. And I do remember that night going into my brother's room, stealing a lot of his Halloween candy and eating a lot of it and not taking my insulin. And that was the beginning of my move into diabulimia. Leslie, next slide, please. So what you see here is a person that looks healthy and happy, but I was not healthy and I was not happy. This was taken about 4 years after the picture you just saw. I lived in a cycle of omitting insulin, binging and omitting insulin for almost a decade. And I continued to be in a lot of denial about how dangerous it was. I was also in denial about how much it was becoming the sole purpose of my life and how it was dictating all my thoughts. My acting career was moving forward. I was constantly working, and I would go through cycles where I would try to take a little bit more of my insulin so that I could perform better and I wouldn't go into DKA. But I lived with this secret every day, and it became more and more apparent to me how much I knew I couldn't tell people about it, and I knew it was wrong, but I also didn't know how to stop. Leslie, next slide, please. This is a picture of my honeymoon with my husband. I met him when I was 22. We were married we met but early when I was 22, and by the time I was 23, we were wed. We loved each other. We knew it right away, and so this is on our honeymoon. I brought 2 scales in my luggage on our honeymoon cruise. My husband did not know this. That's how bad my eating disorder had gotten at this point. I have no idea why I thought they would be effective on a boat, because it's not stable ground, but I just need to stress that that's where my head was. That's how strong my eating disorder pull had become at that point. I also have no idea how I was able to hide it from him. At this point, I was taking a little bit more insulin so that I was not passing out and I was able to keep up on our honeymoon, but I was still extremely disordered in my head about my condition. Leslie, next slide, please. I wanted to make sure that I'm sharing that I had a combination of eating disorder symptoms, and again, after 10 years of them, people who do struggle with eating disorders know that your symptoms can change over time, and you can kind of hop from one type of an eating disorder to another. So mine started with food restriction. The first 2 years of my eating disorder were primarily that. Over exercising, and I was very conscious of trying to hide that to not look like I was obsessive. But then it did transition into my binging and then insulin omission. Obviously, there was severe exhaustion with all of this because of all of this happening to my body. Leslie, next slide, please. So my reality, by the time I was 23 and married, when I should have been in the best time of my life with my new husband, our new life starting out, my reality instead had become insulin omission. It is the fact that I had not told a soul, and I had no idea how to tell anybody. And unfortunately, the saddest reality is that in the 10 years that my A1C was elevated over 14 or 15, none of the doctors I saw asked me about it. My weight was fluctuating up and down. My A1C was constantly high. I was never asked about my emotional or mental health, ever. And that's really, I think, quite a tragedy in the clinical system. Leslie, next slide, please. So the turning point for me when I decided I really needed help and I had a problem was the fact that I was starting to lose my acting jobs. When you're a union actor, you have a gig and then you move on to the next gig. You have some gigs lined up. I was now losing lined up gigs because I was becoming an unreliable performer. I wasn't able to show up and perform 7 days a week, and on the weekends 2 shows a week, because I was so sick from all of my eating disorder symptoms. The major turning point, however, was that I was actually starting to Google methods of suicide because I just didn't know what to do. I was feeling so stuck and I was so ashamed. And that is when I decided to tell my dad about what was going on and make an appointment for an intake assessment at an eating disorder treatment facility. Leslie, next slide, please. So I obviously went to treatment, and I had the support of everyone around me, but I also had the tough love of my husband. And he told me that he did not get married to someone to watch them die. So that really pushed me, and I realized that no matter what, I had to get better. And so the important factors for me, and what I have found in most of the clients I work with, is that in order for this to work, you have to accept treatment. And another way to approach that concept is that you must surrender to change. You must accept that your life will have to change, and it will take time, but you have to embrace the fact that recovery is going to be your new way of life. And the long-term commitment to recovery comes into play in the fact that there are going to be challenges, there are going to be slips. That is so normal, and it should be assumed in the recovery process. But the long-term commitment to getting back on track, no matter how much you've fallen in recovery and in the process, that long-term commitment is an absolutely key factor for successful recovery. Leslie, next slide, please. The other thing is that on a very specific basis to this community, I had to learn how to accept my chronic illness. And that was harder for me because I'd grown up with it. I didn't really remember my life without it, but I'd never really gotten a grieving time to talk about how much it sucked, how angry I was, how different I felt in high school, and just how pissed off I was that I had it. And I was able to have that opportunity to go through all of those feelings with a therapist in treatment. And it really was an important factor that I had not known needed to be addressed, but it was a very important factor in my recovery. Leslie, next slide, please. This is what recovery looks like. It's joy in my eyes, and it's health, and it's the ability to laugh and have a photo taken without worrying what I look like, worrying that my cheeks look too fat or whatever. I love this photo. I love both of these photos. And my journey has been very long. I have a number of health complications that are now part of my life due to the insulin omission that I struggled with for so long, but I would not change any of it for the world. I have learned so much about myself. I have now been given a second chance at life to help others through We Are Diabetes, and I'm truly grateful actually for the challenges that I've had, because now I know that I want to live and I know what is important in life. And with that, I will turn it over to Narissa.
Well, thank you, Asha. We really appreciate your willingness to collaborate with us on this webinar. My hope is that others that may be struggling may find inspiration and hope from your willingness to share your story of recovery. So just a quick overview of what I'm going to be discussing today. We are going to go over the basics of type 1 diabetes, contributing factors, signs and symptoms, and effective treatment approaches to dealing with diabulimia. And I want to start today by providing some statistics, okay? And I got these from the American Diabetes Association and the Juvenile Diabetes Research Foundation. If you're looking for additional information on type 1 diabetes, these are both great resources. You can find these online to get more information about the disease. So there's approximately 1.25 million American children and adults that have type diabetes. In the year between 2001 and 2012, the annual incidence of diagnosed diabetes in youth was estimated to be at almost 18,000, specifically with type 1 diabetes. There are 40,000 people that are diagnosed. Next slide, Leslie, I'm sorry. There are 40,000 people that are diagnosed each year in the United States, and there are 5 million people in the United States that are expected to have type 1 diabetes by the year of 2050, and this will include nearly 600,000 youth. Between 2001 and 2009, there was a 21% increase in the prevalence of type 1 diabetes in people under the age of 20. And now we are seeing more adults than ever before that have been diagnosed with type 1 diabetes, and the rates within the pediatric population, they continue to steadily rise. And as we get more into the presentation and the statistics, you will see why type 1 diabetes and eating disorders will be more and more prevalent in the years to come. Next slide, Leslie. All right, so you may hear this called type 1 diabetes. It was once known as juvenile diabetes, or also you may hear insulin-dependent diabetes mellitus. Currently, the term that we use is type 1 diabetes, and this is an autoimmune disorder, as Asha spoke about. And I want to, next slide, I want to start by providing some basic physiological facts about type 1 diabetes. This is not caused by eating too much sugar. That's one of the myths that I hear a lot. This occurs from an internal physiological process that goes wrong. This is something that's completely out of their control. This is not due to poor eating habits. This is not type 2 diabetes. That is a very different disease. And if you will be working with these clients, it is essential to understand what this disease is, because it has a huge impact on their daily life. So autoimmune disorders manifest in various ways and within different regions of the body. But what is common of all autoimmune disorders is the body mistakenly attacks its own healthy tissue, and this causes disease and injury in the area of attack. So as Asha described as well, these can run in pairs. If you do have a client with one autoimmune disorder, later on that individual might be diagnosed with 1 or 2 more autoimmune diseases. So one that we commonly see with, or 2 that we commonly see with type 1 diabetes is celiac and Hashimoto's. So that's a triad that we commonly see, but certainly it can be any other autoimmune diseases that may manifest. They do not discriminate. Next slide. So what defines type 1 diabetes specifically? The characteristic feature for type 1 diabetes is the selective targeting of the insulin-producing beta cells, and these are found within the pancreas. The cause of the autoimmune response remains unknown, but it is believed to be a result of genetic and environmental factors. And despite enormous advances in the study of type 1 diabetes, there is still no cure, and both genetic and environmental factors remain undefined. Next slide. So on the left, you will see a picture of our cells and our capillaries. Within a normal functioning body, the beta cells will secrete insulin into the bloodstream. And on the right, you can see that because the beta cells have been destroyed, there is no insulin available within the bloodstream. Next slide. So why does insulin matter? Well, all of our carbohydrates, sugars, starches that we eat, they're all broken down into glucose. And glucose is taken into the cell and used for energy. Insulin is a key that unlocks the cell, and this allows for the cell to receive glucose and replenish our energy stores. Next slide. But because the autoimmune attack has destroyed the insulin-producing beta cells, there is no insulin available to unlock the cells, and that means that the glucose is just floating freely through our bloodstream. And this is what we call hyperglycemia, or you might commonly hear high blood sugars. And the free-floating glucose that's found within the bloodstream is what leads to that microvascular and macrovascular damage. The damage that we can see microvascularly will include coronary artery disease, peripheral vascular disease, and cerebrovascular disease. And then the microvascular complications will include damage to the capillaries, and these are all the small blood vessels, and this causes retinopathy, neuropathy, and nephropathy, and these are the things that affect our eyes, our nerves, and our kidneys. Next slide. And here's a good visual. As you look at the white glucose crystals in this picture, this is a very simplified explanation of what occurs, but if you can imagine, as the glucose runs through our bloodstream, making it kind of gritty and thick, and as this goes throughout each and every tiny little capillary that we have, it can cause the vessels to narrow, to roughen, and to bleed. And this is what happens with uncontrolled diabetes. And the glucose in the bloodstream is directly correlated to the damage caused from the diabetes. Next slide. So again, as we discussed, hyperglycemia is caused from not enough insulin. Signs and symptoms to look for would be increased thirst, excessive urination, excessive hunger, and with prolonged hyperglycemia, you're going to see a dramatic weight loss. And this occurs as the body breaks down fat and protein for energy. And in addition to that, calories are lost through excessive urinating. Once a diagnosis occurs and insulin therapy starts, we will then start to see hypoglycemia, and this is caused from too much insulin. Signs and symptoms related to hypoglycemia would be sweating, shaking, blurry vision, poor coordination, dizziness, feelings of lightheadedness. They will have difficulty concentrating. They may be really anxious or irritable, very hungry, may feel nauseous, and you'll definitely see a change in behaviors. Next slide. So diabetic ketoacidosis is a term that we use to describe the rapid development and life-threatening result of untreated hyperglycemia. So when the cells lack adequate glucose to utilize for energy, the body becomes really resourceful, and it'll start to burn our stored fats and use that for energy. And so this causes acid and ketones to build within the body. So when you have hyperglycemia, ketosis, acidemia, these three things equate to diabetic ketoacidosis. And this is the most severe acute sign of untreated hyperglycemia. Next slide. Signs and symptoms that you'll see with DKA, you'll see flu-like symptoms. So there may be vomiting, they may complain of abdominal pain, a distinct fruity odor on the breath, and they will also be passing a high level of ketones in their urine. And if this is left untreated, this does result in dehydration. It can end in diabetic coma, cerebrovascular edema, and then death. Next slide. So often, upon diagnosis, or if there is selective omission of insulin taking place, the patient may present with DKA. And once diagnosis occurs and insulin therapy begins, you will see a dramatic difference in weight. So to the left, we see a little boy before insulin therapy, and to the right, we see the same little boy after insulin therapy has begun. Next slide. To date, the medical management of type 1 diabetes is aimed at controlling hyperglycemia. And we accomplish this by replacing the insulin that the body no longer produces by either injecting insulin through syringes or infusion through an insulin pump. Injections and/or infusions, they require a fast-acting insulin bolus. And we use this when eating food, right? So the insulin ratio is matched to the carbohydrate count that they're eating. And in addition, there will be a longer acting insulin basal dose, and this is used to help stabilize the blood sugar during fasting periods. Next slide. This requires the individual to check their blood glucose levels and inject or infuse insulin multiple times per day. Next slide. And even with deliberate care, there is a high risk of developing life-threatening high and low blood glucose levels. This does require constant attention, 24 hours a day, 7 days a week. There are no breaks. Individuals and families, they may feel overwhelmed by the burden of diabetes care, and one may experience diabetes fatigue. Next slide. Research shows that depression, anxiety, and resilience should be considered in the design of a multidisciplinary approach to type 1 diabetes, because these factors are significantly correlated with glycemic control. However, this is often overlooked. The emphasis instead is placed on the insulin, controlling the selective food intake, counting carbohydrates, and exercising. It's just important to remember that this is a disease that remains with that person throughout the lifespan. So patients and caretakers, they can become very burnt out. And often the psychological aspect of the rigorous requirements to stay alive and to stay safe, they're being missed in our standard treatment of care. Typically, when a patient walks into the doctor's office for their quarterly checkup, aspects of depression, anxiety that they may be experiencing related to their health, or how they are emotionally handling the day-to-day grind of what is required, it's not even being touched. So we know, though, that the research does show us that the correlation between how well glycemic control and emotional well-being are very closely connected. Next slide. So here I have a picture. This shows 22 factors that can affect blood glucose. And you can see there are multiple things, both environmentally and biologically, that can affect the blood glucose levels. So food, medication, activity, biological issues, environmental factors. Some days blood sugars may be better than others, and some days you can physically do everything right and still have a bad diabetes day. Individuals may feel a great deal of frustration and may feel a lack of control over their body. Next slide. So what is diabulimia? Well, in the clinical world, we call this eating disorder and diabetes mellitus type 1, commonly referred to as diabulimia. This is recognized within the medical community, but it's not yet recognized by the DSM-5. And this describes an individual with type 1 diabetes who intentionally omits or reduces insulin to lose weight. It is most commonly seen in adolescent girls, but this is also seen in all ages, both males and females. Next slide. Adolescent girls with type 1 diabetes are 2.4 times more likely to have an eating disorder than their non-diabetic peers. Omission of insulin is the most common weight loss strategy reportedly used by type 1 diabetic adolescents. And between 30 to 40% of adolescent girls report using insulin omission as a weight loss technique. When I first dug into the research studies that have been done on diabulimia, I was shocked at the prevalence and the statistical data that's available. And I want to point out with these statistics that we see that although many of the studies have focused on adolescents, what I've seen that this disordered relationship with food and insulin can begin in adolescence, but often it's not until adulthood that treatment is sought by the individual. Next slide. So how does the required disease management factor into the beginning of disordered eating? Well, first, there is a total disruption of normal eating patterns. So if an individual is experiencing hypoglycemia, low blood sugar, physiologically, they feel the need to eat, and the body requires food, and they feel this urgency to eat fast. And also with hypoglycemia, there are cognitive abilities that are disrupted, right? So they're not thinking clearly. And so to treat the hypoglycemia, a binge may occur. They may overeat, and this is common when treating low blood sugar. And in turn, the result of the binge eating, we see hyperglycemia. So now they have a high blood sugar. If they attempt to correct the binge with a dose of insulin, that can be really difficult to accurately dose, right? Because they're not thinking straight. They weren't paying attention to portion sizes. And so this can equate to them giving themselves too much insulin again. And so then another low blood sugar can occur. And then the binge occurs again to treat the low blood sugar. All these things can equate to weight gain. They can have feelings of guilt and shame due to the weight gain. And obviously, oftentimes in adolescents, body shape, appearance is very important to them. So you can see how these factors may contribute to the development of an eating disorder. Next slide. So I appreciated this quote that I found because I think possibly in our well-intentioned approach to managing diabetes, the professionals working with the population, they may be contributing unknowingly to the progression of disordered eating patterns by suggesting regimented solutions to disease management. Patients with diabetes have a different relationship with their body and food when compared with other people. Since the disease affects various daily activities in their life, including meal times, nutritionist incentives for these patients to follow an eating plan can be a risk factor for eating disorders. On the one hand, patients do not eat according to their sensations of hunger and satiety, and on the other hand, there is a major focus on food and calories that may imply restricting certain types of foods. Next slide. So there was research done at Joslin Diabetes Center by Dr. Anne Gobel-Fabry. I hope I pronounced that correctly. I know Asha knows her, so hopefully I didn't botch her name, but I pulled this model from her research as it gives us a really good explanation of how disease management can progress into disorder behaviors. So current treatment recommendations are that the individual remain within a near normal blood glucose range, right? So we would consider that to be comparable to a non-diabetic. And this expectation can be very difficult to achieve, and this may promote perfectionistic ideals. If the glycemic control does improve, you will see weight gain. And so this can cause guilt, frustration, or an intense fear of gaining weight. And also, there is a focus on the amount of carbohydrates that is eaten to match the insulin dose that they require. So the focus of each mealtime and snacks are on carbohydrates, calories, portion sizes, right? This is our standard treatment of care for diabetes. However, this can elevate feelings that to be successful, they need to be rigid with their diet. And so restriction may begin. We know that restriction is a precipitating factor for the binge purge cycle to occur. And in this case, the individual purges by way of insulin omission. And also, long-term hyperglycemia is linked to depression. And also, they may develop a sense of failure with their diabetes management. So when insulin omission becomes a regular part of their eating pattern, they physically do not feel well. Depression may manifest. Then you add on they're fearful of gaining weight. And they may begin to believe that they cannot achieve health and wellness or be successful with their disease management. Next slide. Other contributing factors. Individuals may initially perceive insulin omission as a rewarding experience. There are no visible side effects, and ultimately they lose weight. Next slide. They may also receive positive feedback from their family and friends regarding the weight loss. They may feel like they've mastered their body, and they may express feelings of control over a body that often fails them. And they may have feelings that they've discovered the secret of how to lose weight without others knowing. Next slide. Signs and symptoms to look for. We want to look for irregular eating patterns. They may be avoidant of sweets and fats. They may gravitate towards safe foods. You may see restriction of food. They may be avoidant of meal times. Restriction leads to binge. We see this often. And so with a binge, this will create feelings of guilt. You add on a fear of weight gain, and all these things equate to limiting or omitting the insulin. Next slide. You may hear them voice body dissatisfaction. They may remain within a normal weight range. They may be overweight or they may be underweight, and they may display an intense obsession related to their weight. Next slide. You will see consistently high HbA1c scores, and what this is the range of blood sugars over a 3-month period. They may be avoidant of their doctor's appointments. They probably will be lying to their doctors and family about their blood glucose values. You may see frequent visits to the ER for diabetic ketoacidosis. However, they may have figured out how to avoid DKA, yet still frequently omit the insulin each mealtime. And you'll see the signs and symptoms of hyperglycemia, right? So it's the frequent urination, excessive thirst, increased food intake. And I just want to make note of how avoidant they may be of their 3-month checkups with their endocrinologist, right? Because the A1C, it doesn't lie. This is a blood test that is done, and it does give us a very accurate indication to the doctor of how well they have been managing their diabetes. So this is not something they can manipulate. Next slide. And as Asha described as well, you may see overlapping symptoms of other eating disorder behaviors beyond the insulin omission. So you would look for restriction, purging by vomiting, use of laxatives, or overexercising. Next slide. So what can we do as providers to identify this population? It is important to acknowledge that this often remains unrecognized by healthcare providers and families. Diabetes providers should incorporate a high degree of suspicion of eating disorder behavior within this population. And we need to be prepared to ask identifying questions surrounding their feelings, their food choices, their weight concerns, and the impact that the daily diabetes management is having on their life. The individual may be quickly written off as a non-compliant patient, and in turn, we are totally missing this and what the underlying issues are that are going on to create these high A1C scores. And diabetes education alone is not enough. Education is certainly important throughout the lifespan with any chronic illness. However, the patient typically has a basic awareness of what they should be doing, right? They feel a great deal of shame over the behaviors, which means they're not talking about this in their doctor's appointments. Next page. So, I apologize. There are screening tools available. The Diabetes Eating Problems Survey Revised is a diabetes-specific screening tool for disordered eating. This is a quick, self-reported assessment that can be completed in just a few minutes. It's easy to use during a routine visit. And research does show that it has excellent consistency and validity in identifying these concerning behaviors. Next slide. So, how many of you have walked into a doctor's office or any type of healthcare provider and felt intimidated? Would you fill out a screening tool honestly? If you suspect that insulin omission may be going on, are you providing a setting that they would feel comfortable disclosing to the nurse or physician, dietitian, therapist, whoever that they're interacting with, that they are acting on these behaviors? While treating anyone with an eating disorder, we need to ensure that the person feels safe in disclosing what they feel are shameful and hidden behaviors. So with that, we have got to maintain a non-judgmental approach when dealing with these individuals. We need to ask very specific questions because we need to identify the exact behaviors that are involved. Are they omitting insulin? Are they administering too much insulin? Is there insulin pump manipulation? What type of dietary manipulation is going on? Is it restriction, binging, and purging? Is there a careless disregard for their doses and values of insulin? And what other compensatory behaviors are occurring? Are they over-exercising? Are they abusing laxatives? Next slide. It's important to recognize that we are dealing with two complex conditions here. We have type 1 diabetes and we have eating disorders. So this does require a multidisciplinary team approach that incorporates knowledge of both. The treatment team must communicate so that all aspects of care align and that all manipulations and behaviors might be identified and addressed. When it is appropriate, we recommend beginning with inpatient or residential treatment so that the diet can be tightly controlled and the insulin requirements can be clarified to match the appropriate diet. So this is very important because at this point we do not have a good idea of how much insulin will be required for good glycemic control because this has been manipulated by the patient. So it's very important to make those insulin changes slowly with the goal of slowly decreasing their A1C score as they progress in treatment. And we do this to avoid further complications. Next slide. All right, so then we want to identify the intended biological outcomes of the behaviors. So we want to identify the blood glucose kept high, kept low. Is there a total denial of need for insulin? And you may see the full spectrum of all these behaviors in revolving stages in the same individual. Purposely keeping their blood sugars high may have began because it was intertwined with a fear of experiencing a low. That's not a pleasant feeling. And then weight loss occurs, and that's when the disordered behavior may have began. Or purposely allowing for low blood sugar to occur by injecting too much insulin. This may be related to suicidal ideation or fleeting thoughts or plans to overdose on insulin. This is something we hear as well. And there may be rebellion, anger, sadness related to the day-to-day maintenance that's required of this disease. Or there may be denial that insulin is even necessary to maintain safety and longevity. Next slide. And then we need to identify the psychological factors that are correlated with those behaviors. So what are the messages that they've received around weight gain? Do they feel like they have lost control? Do they feel like they're bad with their diabetes care? Are they fearful of being seen as sick or lazy or weak because they're not controlling their blood sugars measurably to the way that the endocrinologist would like to see? We need to identify the messages that they've received around those issues and how does it correlate and how is it integrated into the insulin omission. Next slide. In inpatient or residential treatment, the registered nurse will administer the insulin and monitor the blood glucose. Insulin pump settings should always be verified before administering insulin. Registered dietitians should complete an accurate carbohydrate count. Staff should portion all meals and snacks. And all food groups, types of foods, all those things should be included with the goal of balance, variety, and moderation. Next slide. We will gradually allow the client more autonomy around insulin administration and portioning of food and practicing those carbohydrate counts. However, this is contingent upon the individual committing to proper insulin administration and their willingness to verbalize and process urges to manipulate. Next slide. And then as they progress through treatment, if partial hospitalization and intensive outpatient treatment is involved, we'll allow even more autonomy at that point if the individual is displaying an appropriate relationship with administering insulin and following their meal plan. If the individual is unable to commit to their treatment plan or is displaying evidence that supports insulin manipulation or other eating disorder behaviors, this may require a step up to a higher level of care. And we can anticipate that with improved management of insulin and the associated weight gain, there is a prevalence for relapse. Next slide. So what sets Castlewood apart from various other treatment facilities? We do offer residential, partial hospitalization, and intensive outpatient programs. In addition to medical and dietary management, there is a focus on identifying any trauma and underlying issues that may be fueling the eating disorder. Clients are involved with intensive individual and group therapy. There is often co-occurring depression, anxiety, anger connected to the day-to-day requirements of disease management, and all of these factors will be addressed. We have direct care staff that portions and then eats meals with the clients. We have nursing who administers the insulin and manages the insulin pumps and continuous glucose monitors. We have dietitians who develop individualized meal plans and identify and challenge the disordered eating behaviors. And the goal is to develop healthy eating patterns that include all food groups and help them to regain a sense of hunger or fullness awareness. And we have therapists who will identify and process underlying psychological factors and traumas that may be integrated into the maladaptive behaviors and the insulin omission. And psychiatrists who pharmacologically treat not only the eating disorder, but the co-occurring issues as well. And in addition, they will build upon the therapeutic work that the client is working on with their therapist. There is frequent collaboration with the client's outpatient endocrinologist as well, because they will continue to monitor and adjust the insulin as the client progresses through recovery. Castlewood uses a collaborative and multidisciplinary treatment team approach, and each client will have an individualized treatment plan. Next slide.
All right, it's Asha Brown to finish up. So with that being said, with just what Narissa was talking about, the multidisciplinary team, that is a really important component to successful recovery for EDDMT1. And so I'm going to talk about some of the team members in that and some things to look for individuals who are listening who are not providers, but individuals struggling themselves who are information about how to build the best care team. Leslie, next slide, please. So we're going to talk about the suggested list of providers for your recovery care team. I want to mention that this suggested list was actually built within the We Are Diabetes workings. The board of directors and I came up with this list, and there's a resource where you can find all this information that I will share at the end of this presentation. So to start out with, as Narissa mentioned, you need a licensed psychologist and or psychiatrist to manage not only the emotional hurdles of the eating disorder when you're going through recovery, but the usually possible and usually quite common co-occurring mental health conditions that can come along with eating disorders. You also need a general practitioner, medical doctor, and again, this is for someone who's potentially trying to find these providers and they're not all in the same place in a treatment center. You need this person to get referrals to other specialists to help manage potential edema and other general health concerns that can flare up in initial recovery. We also suggest getting work with a registered dietitian. It's more important that we have found through the work I've done and through my clients' experience to have a registered dietitian that has eating disorder experience rather than type 1. Obviously, we would love if they had both, but that is very difficult to find. So if you're wondering what to kind of hone in on when you're looking for an RD, look for someone who has eating disorder experience, and then obviously contact We Are Diabetes, and we can help you provide materials to this RD so that they can get a better scope of how to support someone with both an eating disorder and type 1 diabetes. Next slide, please. Moving on with this suggested list, obviously you need an endocrinologist to monitor your diabetes management. We also highly recommend that you also work with a CDE along with the endo. Usually you get more time with a CDE, and the CDE can help you manage the little intricacies that come along with the program that you and your endo have set up. We also, and many people don't mention this, but we also recommend connecting with a physical therapist. When you are transitioning into recovery as a type 1 diabetic, you will probably have some flare-ups of pain. It can be neuropathy. It can just be your muscles reawakening, getting glucose back. But a lot of our clients do suffer from pain, and they need to relearn how to use their body again. They also need to learn how to exercise in a moderate way and manage their blood sugars throughout. Again, there'll be more information that we can share at the end of this. Next slide, please. So the essential factors in choosing your recovery team, again, if you're an individual trying to pull this team together yourself, is most important is that these providers that you choose to work with must be willing to learn about the complexity of type 1 diabetes if they're not already familiar. They also need to be willing to learn and listen to how it plays a role in your eating disorder. If you as an individual are having trouble getting this information to them or being able to vocalize it yourself, We Are Diabetes has tools and support channels to help you with that. So we can help our clients and people reaching out to us start to have those conversations. It's also important that the providers you choose must be willing to communicate with the others in your care team, even if that means they have to reach outside their clinic system to do so. So it means they have to be willing to maybe go that little extra mile in order for everyone working with this individual to have the information on the same page as they move forward and support this person in their recovery. Next slide, please. The providers must be collaborative and they must be non-judgmental. Obviously, there's no room for judgment in this process, and I know from personal experience as well as with my clients that sometimes that can be very hard to find. And again, We Are Diabetes has ways to help our clients find providers and work with providers so that they can get out of that no judgment zone. It's also important that these providers do not push to make changes too quickly. It's been reported in multiple places, and unfortunately we've learned from the past mistakes is that if you lower your A1C too quickly, it can cause damage to the eyes and nervous system, and it can be irreparable. So you need to be working with an endo and diabetes team specifically that understand it's better to go slow and steady as you reduce your A1C. Next slide, please. So to finish off, I want to make everyone aware of an important resource that is available for free. It's the We Are Diabetes Recovery Toolkit. The hyperlink is there posted. If you go to wearediabetes.org and go to the resources page, you can also access it that way. This addresses the most common concerns and questions about the recovery process. It also offers more detailed information about what I just spoke of about choosing a recovery care team. It even offers information about how to avoid binging when you start to experience low blood sugars in recovery. We've gotten national recognition for this, and we've gotten great feedback, and it's something that is not only helpful for providers, but it's also helpful for family members who want to gain insight into their loved ones' struggles. So we're very close to finishing off time here, so I'm going to wrap it up. If there's any questions, I and Narissa are excited to answer them.
Hey, it's Leslie. It looks like there is a couple questions. Let me see if I can read these for you. Yes, someone's asking about copies of the slides. The slides will be posted as well as a video of the webinar on the Castlewood website. Within the email that you will get following, it will include a link for you to access those. You will have access to them. And yes, there will be a way to rewatch the lecture. It says, here's one question. Please remind me what happens biologically when a client omits insulin.
Biologically, well, I feel like Narissa kind of covered that. The process of going into hyperglycemia, you know, if you look up the information about what happens when your blood sugars for an elevated period of time, that is what's biologically happening when you omit insulin. It is the process of prolonged high blood sugars. Narissa, wouldn't you agree? Maybe she's not there anymore.
Say, Narissa may still be muted.
Yeah.
And then the last question, someone's mentioning, I'm a dietitian in a peds endocrine clinic, and I'm always worried about giving patient ideas when asking about these behaviors.
That's a great question and concern to have. Yeah, for me, when people ask me to come and speak to their teens about diabulimia, I say no. Because you have right to be concerned. You don't want to bring it up to impressionable minds. That's why I believe with Narissa talking about screening tools, I think that kind of stuff is much more important. But it's not necessary to be offering this information to people, especially teen type 1s. It's more important to stress positive body image, finding healthy ways to cope with stress and anxiety, and to focus more on those larger scale things. And then, of course, if you have concerns about a certain individual, to start talking to them about it, you know, and letting them know there's resources and help. But there's no need to be offering lots of information about diabulimia to every teen or you know, type 1 that you work with, especially if you're not seeing a need for concern. That's my personal take on that.
So we are running a bit long, so I'm going to go ahead and wrap up. There are a few more questions that were not answered, but we will circle back and answer those direct with those that asked them. So I want to thank everyone for attending today's session. And just a reminder again, over the next couple of hours, you will all receive an email. The email includes a link to a survey. You must complete the survey in order to receive your certificates. Certificates will be emailed out in 5 to 7 business days. In addition, a recording and the slides from today's presentation will be available online, and within that email you will get a link to where those are available online, and those should be up within the next 24 hours. So again, thank you everyone for attending. Have a great day.